providing me this opportunity to be with you all. Uh, we all know that growth is one of the best indicators of overall health of an individual. And when we talk of growth, we need, first of all, to measure it, and then we need to compare it with whatever normal and decide whether it's abnormal or not. Uh, we do know of the expectations, unwarranted expectations in some instances of parents of wanting their children to be tall like anything. And in this context, maybe showing the growth on a chart sometimes helps, and also putting in context the height of an individual as expected out of the height of the parents. So in this evening, I have a relatively small role to play, just a supportive one for the really interesting talks ahead of me. So when we talk of growth charts, we mostly look at the heights, but it's important also to look at weight. There are also BMI charts available. Head circumference is something that is there, but I must admit that as endocrinologists, we possibly pay less attention to head circumference, which does not mean that it's not important. The pediatricians, of course, utilize it much more. As we understand, of course, growth charts are intrinsic to the practice of pediatricians. And of course, for endocrinologists, it's also very important. And what I'll talk about is possibly carrying a coal to Newcastle, because you all are more adept in using these growth charts maybe than many of the other physicians. And some basics first, of course, up to the first 2 years of life. After birth, we look at length, and it's all in centimeters, not in inches, to try and make it more accurate. After 3 years, it's height. Between 2 and 3 years, it's suggested that you measure both length and height. This is, of course, taken from a textbook, an infantometer, how it should look, how it's done. And one needs to be, of course, careful. One needs also got to make sure that the position is proper. And we see the very firm, of course, the headboard and also the footboard being sliding, but it's how sturdy it is in an ideal situation. I must admit that at least me in my hospital in IPGMER, this is what we have by way of infantometer or stadiometer, if we call it, for infants. And clearly they are not as robust, as good as the ones that we saw in the picture. Hopefully at ICH you have better ones, but we have to make do with what we have. And this is for children above 3 years of age. Standing height is measured. And this is an example of a Harpenden stadiometer. Once again, see the headboard is quite broad and it's quite robust. And there doesn't seem to be much play possible of the headboard swinging up or down. It can only sort of move along a vertical line, but not rotate along or around the horizontal axis. We all know that we should be doing 3 measurements. That's ideal. And the difference between 3 measurements should be less than, any 2 measurements should be less than 0.3 centimeters. I must also admit that despite being an endocrinologist of some duration, sometimes I am a little bit taken aback if I check the height twice or thrice and see a difference of even up to a centimeter. But that's partly because of the stadiometer that we use, and also because of other factors like positioning. Now, when we talk of the head in the Frankfurt plane, we know that it should be the Frankfurt plane should be parallel to the ground or to the should be horizontal. And this is a plane that passes through the lower bony margin of the orbits and the upper margin of the external auditory meatus. Now, we are told that in an ideal world, the back of the head, the thoracic spine, the buttocks, and the heels should touch the meter. I would like to point out that this often does not happen in reality, especially if you are measuring an obese individual. This on the right is an adult, I admit, and the stadiometer that is being used, what is being used for measuring height, is a euphemism for a stadiometer. But nonetheless, we have to work with these instruments as well. So clearly here, if the buttocks are touching the wall, then there is no way that the occiput and also the heels can also touch unless the head is tilted upwards. So no longer will the Frankfurt plane be satisfied. So in these cases, we need to have a gap remaining between the occiput and the wall or the meter, a proper meter. And this is what we have. This is a Seca stadiometer we have on the left for this small girl, which is amongst the better makes. But even then, see, this headboard is not quite wide enough, not quite firm enough, and this allows some amount of rotation around a horizontal axis, making the measurements not as good. Now so that was about how to measure. And then about the growth charts, we remember among so many different charts, there are two broad types of charts. One would be the standard charts, growth charts, the other, the reference charts. The standard is sort of what would ideally happen if the child had absolutely optimum, everything optimum around him or her. The reference is how this child is growing under the best possible conditions or environmental situation for the given place and socioeconomic status, etc. So if we compare between the two, standard versus reference, the standard is an international sort of database, and it allows you to compare between different races, ethnicities, regions, or socioeconomic strata. Whereas the reference chart is representative of a given country or a given community. And then the standard growth charts possibly do not change significantly over time. But for the reference ones, you need to have those being updated from time to time, assuming that that particular country has not yet reached the optimum socio-demographic conditions. So then you can look at the secular trends in that given country. And so it needs to be updated. And again, even if you look at the standard growth charts, it is usually up to 5 years. Beyond 5 years, it's thought that the number of variables contributing to the growth are too many to control for. The example of a standard chart is the WHO growth chart, which was derived from the MGRS, the Multi-Center Growth Reference Study, which looked, as I mentioned, at healthy children without significant morbidity, and the definitions of health are enunciated in this slide. And they, however, because it was a WHO chart, they took representation from across the globe. From India, it was New Delhi, then it was Muscat, then it was Oslo in Norway, Accra in Ghana, in Africa. And then you have South America represented, and you have North America also represented. But in all these places, you have optimum conditions it is issued, and then you prepared this growth chart, the standard WHO growth chart. So a few growth charts in the global context. One of the earliest ones was the National Center for Health Statistics in USA. And then you have the WHO MGRS 2006, the standard growth chart from 0 to 5 years. Remember, from 0 to 2 years, it's a longitudinal, the accumulation of data is longitudinally collected. And from 2 to 5 years, it's cross-sectional. And then you have the CDC growth chart of 2000, which is a reference chart for USA, basically. So they have got two parts, from birth to 3 years, and also from 2 years to 20 years. It's a cross-sectional in nature. And I do not exactly understand why, but if you look at the girls, this is the CDC 2000 growth chart that you all may be acquainted with. The chart for the girls has from 5th to 95th centile. However, for the boys, as we will see, it provides you data 3rd to 97th centile. And obviously for 0 to 36 months, apart from the weight, height, and apart from the parents' stature, gestational age, head circumference, length at birth, they are also incorporated, which are not there in the 2 to 20 years age group. And this is for the boys, as I said. Now you can have 3rd to 97th percentile. What about growth charts in our context, Indian context? There have been quite a few. Agarwal's charts, then Marwa's, then Khadilkar's 2015, and now possibly most of us would be referring to or using the revised IAP 2015 growth reference chart. It incorporates for the first 5 years, 0 to 5 years, the WHO standard chart. And then from 5 to 18 years, it incorporates Khadilkar 2015 chart. And this excludes children with obesity. So much about growth charts, the availability of growth charts. However, the bottom line is, I personally would think that you could use any chart, provided you follow the same and provided you measure often enough. Of course, when we need to discuss with the parents as to what is normal, abnormal, using a growth chart which is from our own country makes it easier. Otherwise, as I said earlier on, if you use international charts, many of our children may appear to be quite short, whereas by our own standards, they may not be as short, at least in ages, let's say 5 to 18 years. So this is, once again, this is an IAP 2015 chart. Let's focus on the right side. The point essentially I wanted to make is it's important that we measure often enough, document it properly. So this is a girl who was diagnosed with growth hormone deficiency, started on growth hormone, but as happens so often, after about 6 months, the parents ran out of money, couldn't procure growth hormone. And then over the next 1.5 years, look at the growth, hardly any increase. And then we started to have growth hormone being provided free of cost from a hospital. And then again, this child is growing fairly well, but clearly quite below the 3rd percentile. And that's the target height that's plotted there. So if you use whichever chart and follow up, I think you can get, at least in terms of response to treatment, you can get a good idea. Another area that especially I think the younger generation, the students, the trainees would or should be knowing about is how short or how tall an individual is, how do we express it across different groups, populations, and we often take recourse to percentiles. But again, as we know, the lowest percentile that you can have is possibly the third percentile. And you define short stature typically if the height of the given individual is less than the third percentile. But what about heights below that? How do you describe how short that child is? Yeah, we can have less than that also, but not sort of directly demonstrable from your height chart. So there comes in the importance of the Z score. Now, the Z score or the standard deviation score, let's try and remember this way, that's a mean or mean for a given age and sex is the 50th percentile. So let's say the example that we have given here in figures, the 50th percentile, and let's say look at 10 years of age, the height is 137.2 centimeters. So that's the 50th percentile for whatever sex, and this is the age 10 years. And that corresponds to 0 standard deviation score or 0 Z score. At -2 Z score or -2 standard deviation score is the third percentile. And similarly, you can have on the higher side, if it's +2 Z score, then means generally is defined that that child is tall. If it is negative, then that child is short. And if we sort of try and here we have the standard deviation being given along with the height. So how to calculate this Z score or standard deviation score? Well, let's take this example. Let's assume this child has a height of 110.2 centimeters. So if you go down to 10 years, so the lowest that's written here is 123.6, that's the third centile. So it's even below this. So how much below? Well, the mean is 137.2. So you subtract 137.2 from this child's height, and then you divide by the standard deviation. For this age, the standard deviation is 6.8. So 110.2 minus 137.2, which is, I can see 27 divided by 6.8. Sorry, it's minus 27 divided by 6.8, and that is minus 3.97. So the Z score or the standard deviation score for this height, for this child, is minus 3.97. So it's generally -3 is taken as severe short stature. It is more severe than a severe short stature. And another thing that we can make out is what this current height of the child is. How does it compare with others, or rather, what is the height age? So that is looking for this height, 110 centimeters, and finding out at what age is this the 50th percentile. So it's 110 is something between 108.9 and 111.9. So that's between 5 and 5.5 years. So this child of 10 years is actually at a height comparable to a normal child of only about 5 to 5.5 years. So these tend to give some more perspective to how short a child is. So that's height standard deviation score. And that's where the standard deviation is provided at the end of this chart. However, most charts will not have the standard deviation written for you. So this, again, this is for the trainees. You can easily calculate because you know between the 50th and the third percentile are two standard deviations. We saw that from the last one. So between 50th and third, it is two standard deviation. So if you can calculate from here for let's say for age 10, look at the height, look at the 50th, and also look at the third, and find out what's the difference. And we find that it's 12 centimeters. So two standard deviations is 12. So one standard deviation will be 12 by 2, that's 6. And now we can do the same calculation for standard deviation score. So 110 minus 138, 138 is the 50th percentile height for that age, and divide by the standard deviation, which is 6, and now it's minus 4.7. So you can calculate, even if you do not have the standard deviation mentioned, you can calculate if you put in slight extra effort. And then the important point I was wanting to make, I thought I did mention, that's about serial measurements. We concentrate on the second chart on the right. So let's say we have a child, a boy at age 7 at this point, which is below the third percentile, which is short. But there will be absolutely two different implications for this short child. If he started from this point B, where all along he has been growing a little bit below the third percentile, compared to one who was probably near the 50th percentile earlier, between 25th, maybe closer to 25th percentile earlier, and now has come below the third percentile. So clearly this, for this boy, we have less of a concern, whereas for this boy, we have a greater concern as to something significant must have happened, that the height that this child is going across, crossing height percentile lines going below. So it's extremely important, once again, to measure on a serial basis. Just a single measurement often does not give us the full information. And then we also have height velocity percentiles now available to us for our Indian children for the age 5 to 17 years. And then if someone, especially the juniors, could try and help me interpret these growth charts A, B, and C. A, you start here at about age maybe 2 years and 10 months or thereabouts. And this is the height, this is the weight, and you have progressive, the height percentiles or the child's height crossing percentile lines going below and below to the third centile. And at the same time, the weight also is tend to go low and low. So this would be a typical representative of a chronic medical illness, maybe classically a malnutrition, could be a malabsorption, could be maybe even a chronic inflammatory disease, could be any of these. So here you have not only the dwindling of weight, not only the dwindling of height, there is also dwindling of the weight, which is sort of gives us a clue as to what is the underlying condition. And this is a fairly typical growth chart, as we see falling off after age 10, but the weight is not falling off. Weight is remaining around the same percentile line. So this is typical of acquired cause for growth hormone deficiency, or maybe more commonly juvenile hypothyroidism, where the weight is not much affected, but the height is much more significantly affected. And then the third one, of course, we find that the height has been from around, quite probably there's about age 2, it crossed a percentile line, almost crossed a percentile line, and then growing above the 97th percentile, but eventually stopping at a much earlier age of about eight and a half years. So this is a typical case of a precocious puberty, height showing significant acceleration initially, but the eventual adult height could well be compromised because the height growth stops earlier. Once again, demonstrating the importance of serial measurements. On the left, we find highs just below the third percentile, but then just about making it above the third percentile, and with the menarche happening somewhat later at about age 16. So this is constitutional delay, which we talk about more in boys, but it's there in girls as well. And this could well represent a familial short stature, where weight and height both are significantly below the third percentile. But if you look at the target, sorry, the target height range is also on the lower side. The target height is just below the third percentile. So here, though the child is quite short, putting the target height also on the growth chart helps us explain to the parents that you cannot expect miracles. So you need to have a realistic expectation that possibly this child will be short because the parents also have a shorter target height. And this is a classic example of a hypothyroidism, juvenile hypothyroidism, with delayed bone age being shown there. Possibly, I can only imagine, possibly it's not there. A little bit of epiphyseal dysgenesis, possibly it's not there. And then the beautiful response to thyroid hormone replacement, and the child, girl, nicely getting up in the height percentile curves, but possibly still not reaching up to the full potential. So we commonly see that, say that for hypothyroidism, if we treat them, they gain back full height potential, but possibly unless it's started early enough, possibly even then they have some compromise in their height potential. And this is once again, I think, an example. Now we concentrate on the right side. This is a child with hypothyroidism, child diagnosed with hypothyroidism, started with thyroxine, and then between this and this point, there was no treatment given for whatever reason, and you can see that height increase is very minimum over this course of 4 years. And then of course thyroxine was resumed, and again we see response to treatment. And then we have disease specific growth charts, realizing that you may not be able to achieve exactly the same as a normal healthy child of similar age if you have certain significant underlying diseases which cannot be reversed. But at the same time, one needs to pick up if there is any other added issue to the basic disease process. And then if you follow the growth chart, then you can detect if there is additional disease that is being added to the basic process, like achondroplasia or Downs or Turner syndrome. And in Turner syndrome today, with the availability of growth hormone, and if it's started early enough, the expectation, this is the Turner specific growth chart, and this is a normal growth chart, so that you find that the 97 for the Turner specific and the 3rd for the normal are sort of overlapping, and the target will be to reach possibly the lower part of a normal growth chart. Just a comment about prediction of adult height, which can be done from bone age, the current age, and also partly from sexual maturity. and also taking into account the mid-parental height. There are different methods, the Bailey-Pinot or the Tanner-Whitehouse. I find them not very easy to use, but you can do that, and it requires some time to do it. And so, sort of coming towards the end, as I was mentioning, so we need to know not only this child's height, but we also need to know this child's potential in terms of the height of the parents. So the mid-parental height is calculated, we know, taking into consideration or respecting the average difference in height between adult men and women being 13 centimeters. So half of that is 6.5. So you add to the average of father's and mother's height in a boy, and you subtract that in a girl. But then there is something known as regression towards the mean, so that a child of short parents is likely to be less short than the parents. And also a child of tall parents may not be as tall as the parents. So the target height is this mid-parental height, and then you allow about 20% leeway for the height to be above or below. And the target height range is taken as the target height plus minus 5 centimeter. And I think I have mentioned often enough to make it important that serial measurements are much more important than a single measurement. We need to be aware of even intra-observer variation in the measurements. And of course, there are inter-observer variations. A child crossing its height beyond 1 percentile line per year after 2 years of age is to be taken as abnormal. In the first 6 to 12 months, it is not uncommon, especially in small for gestational age or even appropriate for gestational age, but small babies. There is expected to be significant catch-up growth in almost 90% in the first 2 years. So there is expected to be crossing of percentile lines in the first 2 years of age, especially for small babies. But beyond 2 years, we should take this look at it very carefully. And so finally, we sort of understand that growth charts form an important tool, one of the most important tools, I think, to assess growth in reference to healthy children. We mostly refer to the reference charts. The standard charts are there if we want to know how we compare with the rest of the world to the ideal world. Many of these charts are cross-sectional in nature, we need to remember. But once again, it's important that you use any chart, but use the same chart, but plot sufficient number of points to make good sense out of the reports. And it helps us in a number of ways: early identification of growth failure, some idea about the differential diagnosis of short stature. It helps in predicting final adult height, and of course in monitoring response to treatment. So thank you once again, and I'll stop sharing now.
Thank you, Professor Chaudhary, for your excellent presentation. And I think this will be available in YouTube also, if you don't have any objection, because all our presentations are given in the YouTube.
I'm fine. Yeah, thank you. Sure.
So you don't have any objection, no?
No objection from my side. Okay. And I would like to put on record, actually, one of our one-time student, now consultant in his own merit and right, Dr. Parthopratim Chakraborty. He works with me closely, and he has also helped me put together this presentation.
Okay. Yeah.
So, good evening, my teachers and my colleagues. So I am grateful to, first of all, I'm grateful to Dr. Apurva Ghosh to giving me this opportunity to present in front of this kind of stalwarts in pediatrics and also in endocrinology. Dr. Ghosh is always my guide and will be my guide for my entire life. And also, I think he will give 100 goals to me in pediatric endocrinology also, because I think he knows better pediatric endocrinology than me. I'm grateful to Dr. Chaudhary because I don't think he needs any introduction. He is the stalwart of endocrinology internationally. And thank you, sir, for your nice presentation. I thanks Dr. Morusi ma'am that I started my training in pediatric endocrinology under her way back during my post-graduation days. So I will take very little time. I will present very three short cases of short stature. Before going to my presentation, I think this particular topic, short stature, is the most important topic for the general pediatricians also, because for as a general pediatrician, we have to we are the responsible physicians to evaluate that if any child is short and whom to investigate further and refer to pediatric endocrinologists. So my first case, 4-year-old girl presented with not gaining height and weight. She was full-term baby, normal vaginal delivery and small for gestational age. There was no significant past history or family history. Developmental milestones were normal. So this is the growth chart. Uh, so in this growth chart, we can see that since 2 years of age, there is gradual growth faltering for height as well as weight. And the first thing, the bone age was delayed 2 years, 6 months, height age 1 year, 9 months, tenor stage 1 and vitals were normal. So actually this child was initially evaluated in a different institute. They did the basic soft structure workup like complete hemogram, ESR, renal function test, liver function test, TFT, all were normal. Anti-TTJ IgA was negative. So they go further and did growth hormone stimulation test, where growth hormone peak was low, 4.08, and low IGF-1. So they prescribed growth hormone. So later on, they want a second opinion and came to us. So a delayed bone age girl child with normal soft stature workup and normal anti-TTG IgA. So what was missing in this particular case and what was not done during this basic workup? That is the total IgA level. So when we are doing anti-TTG IgA, we should always do total IgA level along with it, because if there is selective IgA deficiency, the total and the anti-TTG IgA will be negative. So in this case, total IgA was very low, and we did anti-TTG IgG and anti-deamidated gliadin peptide, which was positive, and endoscopic biopsy showed suggestive of celiac disease. So here we stopped gluten, and you can see there is very excellent kind of growth, catch-up growth for this child. So after 1.5 to 2 years of strict gluten-free diet, now we can see that the child is growing at a normal pace. That is, the height velocity is normal, but below the third percentile and parallel to it. So here there is an indication of starting growth hormone, that is failure to catch up in case of small for gestational age. So we started growth hormone here, and you can see there is excellent catch up growth for this child. So there is a excellent guideline and recommendation for small for gestational age growth hormone treatment from the Endocrine Society. As you can see that FDA from US, they are little aggressive about starting treatment, that they keep a cut-off age that is 2 years, and they keep a dose of 70 microgram per kg per day. And the European people are little conservative. They wait till 4 years of age, and their dose is 35 microgram per kg per day. And from Indian perspective, as there is no consensus guideline from India, I think personally that we should wait till 4 years of age to give a time for the small for gestational age baby to catch up. So coming to my next case, 8 years, 6-month-old girl, she presented with progressive breast developments in last 2.5 years. There was 2 episodes of vaginal bleeding. There was not, she was very short, birth history was normal. On examinations, vitals were normal. There was mild pallor. There was facial puffiness, dry skin, depressed nasal ridges, and tanner stage, breast tanner 3, and pubic hair 1. So this is the growth chart. You can see that height is very short and bone age is delayed, that is 5.2 year. So it is correlating with the height age 5 year 2 month. So investigation showed LH, FSH, and estradiol is pivotal, and TSH is very high, 956, and TPO antibody was positive. So we did an ultrasonography which said enlarged multicystic ovaries. So we started treatment with thyroxine, and during follow-up, the ultrasonography showed regression of ovarian cysts, and also there is no further vaginal bleeding. So this was a case of Van Wyk-Grunberg syndrome, which is nothing but an isosexual precocious puberty associated with serial long-standing juvenile hypothyroidism. It is due to high TSH, which cross-reacts with FSH receptor in the gonads, because the TSH and FSH receptor has the same common alpha unit. This is also referred to as overlap syndrome, and the signs of pubertal development regress with thyroxine therapy. And I think a patient with precocious puberty who is short and whose bone age is delayed, there is only one diagnosis, that is hypothyroidism. Coming to my last case, this is a 12-year-old, 12.5-year-old female who presented with no breast development and short stature. Birth history was normal, Tanner stage 1. This is the growth chart. You can see that height is very short. This is the picture of that girl. So initial basic soft stretches workup was normal. Bone age was 12.5 years. So what is the next step? That is karyotyping. Any girl who is short and basic soft stature workup is normal, we should do karyotyping to exclude Turner syndrome, because many a time, many Turner syndrome variant will not give you the typical Turner stigmata. And this patient showed karyotyping 46X with isos chromosome XQ. This is a Turner syndrome variant. And also this patient had hypergonadotropic hypogonadism, USG pelvic source, strict ovaries. So we started growth hormone, and later hormone replacement therapy was added. So we should always put a height of Turner curve on a Turner specific growth chart. This is the Turner specific growth chart. So in a nutshell, how we will manage Turner syndrome. So growth hormone therapy should be considered as soon as growth failure is demonstrated, and many a time a higher dose is needed. There is poor responsiveness of growth hormone to during Turner syndrome, and many a time combination of oxandrolone along with growth hormone after 10 years of age will give you better result. And most girl, but not all, have hypergonadotropic hypogonadism and need hormonal replacement therapy for induction of puberty. Thank you. Thank you.
Thank you, Hriday, for your nice cases. If there is any comment on these cases, we can discuss it afterwards when Dr. Chowdhury and Dr. Mautushi Rai
Yes.
Chowdhury will be able to help us. So may I now request Dr. Mautushi Rai Chowdhury to present.
Uh, Actually, I'm having quite a problem with connection. I don't know how far I'll be able to present the talk. So I have not switched on my video. I'll just be audible, and let's hope for the best. The slides visible, I hope. Hello.
না এখনো দেখা যাচ্ছে না দিদি
Slides তো share করেছি।
স্ক্রিনে হচ্ছে এখনো হচ্ছে মানে এখনো স্ক্রিনে আসেনি
তোমরা মায়াদি জয়েন করেনি আজকে?
হ্যাঁ করেছে হ্যাঁ ঠিক আছে দিদি হ্যাঁ ফুল স্ক্রিন করুন স্লাইড শো করুন
হ্যাঁ ফুল স্ক্রিন করেছি একটু পরে আসছে করে দিয়েছি আমি
ঠিক আছে দিদি স্টার্ট করুন
এবার এসছে
হ্যাঁ দিদি
ফুল স্ক্রিন
হ্যাঁ
ওকে ঠিক আছে good evening everybody it's a pleasure to talk on a platform like this and after that excellent talk by Dr. Chowdhury and the interesting spectrum of cases of short stature by Dr. Hriday, it's now time to talk on growth hormone therapy in growth hormone deficient children. Now, this is our agenda for today. We're touching on indications and targets, initiation and action of growth hormone, define per response, monitor therapy, discuss growth hormone therapy during puberty, the role of adjunctive therapy, growth hormone therapy during the transition phase, adverse effects, and finally, safety issues. If you look at the timeline of growth hormone therapy, actually growth hormone has been available since early 1960s, but that was pituitary-derived growth hormone, and due to its limited supply, its use was restricted to children with severe short stature. And then what happened with the availability of the recombinant growth hormone from the 1980s, due to the unlimited supply, the indications of growth hormone expanded to non-growth hormone conditions, non-growth hormone deficient conditions, including various syndromes and systemic illness. And this is what the list of approved indications looks like. Right now, you have growth hormone deficiency, Turner's, Noonan's, Short's, small for gestational age, idiopathic short stature, chronic renal failure, and as you can see that there are some indications like the skeletal dysplasia and the inflammatory bowel disorders, which are where hormone is approved only in specific countries. And today, for time constraints, I'll be restricting my talk to therapy in growth hormone deficient children alone. Now, why are we treating the child at all? In the first place, we want to provide that initial catch-up growth, and we want to enable the child to reach his or her genetic height percentile. Next, we want to synchronize growth and puberty. And of course, the final aim is to achieve an adult height, which is acceptable for the relevant population group. Metabolic benefits are not very relevant, excepting in cases of severe growth hormone deficiency. And psychosocial benefits of growth hormone therapy is a very dicey area with not enough data to support that a specific height gain or a specific height confers additional psychosocial benefits. Okay. Now, when do we start growth hormone therapy? Needless to say, once the diagnosis is confirmed, we put the child on growth hormone. And the earlier we start the treatment and longer is the prepubertal window for catching growth, better would be the height gain. And obviously, if we are starting late, we have to ensure that the epiphysis is correct at the time of initiation of growth hormone. The baseline parameters, of course, we need to document, which includes the child's height, weight, pubertal status, height, the thyroid function tests, the bone age, deficiency of any other hormones if present, the IgE, and of course the MRI findings. Very importantly, we need to counsel parents. We need to counsel parents not only regarding financial issues, which is a big hurdle in our part of the world, but we must see that the parents do not have unrealistic expectations from growth hormone therapy. Because after spending all that money and all that effort, it is not unusual that their expectations will not be grounded, and so that could be at the end of the therapy. So better to clear up before starting therapy. The whole injection is given subcutaneously, ideally in the evening hours. Daily therapy has been shown to be more effective than thrice week or 6 days a week regimen. 1 milligram equals to 3 units. Pen devices are definitely provided because of the ease of administration and also the accuracy of dose. And long-acting preparations of hormone are in different stages of development. They are available in Korea and China also right now. And they have shown some safety and efficacy in the short-term goal, but long-term data. Hello. Hello.
Hello.
Yeah, I think it got disconnected in between. Am I audible and the screen
You are
visible
audible,
right
but
now?
you are audible, but slides are not visible.
Okay, I'll have to share screen again, I think.
Yeah.
Is it visible now?
Yes, yes.
Okay. I'm facing a hell of a problem today. It had to happen, I don't know why. Anyway.
This is slideshow করুন please.
Slide show তে তো দিয়েছি
হ্যাঁ
আছে না
ওকে 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 নো ঠিক
Okay. Now, so we start with the initiation of growth hormone, and we usually go for a dose-based dose, 25 micrograms per kg per day. If there is severe growth hormone deficiency, we can start at a much lower dose. If we are prescribing growth hormone to infants and obese children for a body surface area guided growth hormone dose. Expected height response in the first year is around 10 to 12 centimeter.
মৌটুসী আবার শোনা যাচ্ছে না।
অপূর্বদা, আমি একটা কাজ করছি, আমি আরেকটা নেট চেঞ্জ করে দেখছি। ইন দ্য মিড টাইম আপনি কি will you take over? কারণ এরকম ভাবে তো বলা
ঠিক আছে,
যাবে না।
আমি
It
আমি
is
আমি শুরু করছি।
very weird. হ্যাঁ, আপনি করুন, আমি দেখছি আমার কিছু এটার ব্যবস্থা করতে পারি কিনা। হ্যাঁ, ওকে,
ঠিক আছে।
আমি ট্রাইং এটা। ওকে।
তোমরা তো আমি শুরু করব।
হ্যাঁ স্যার, শেয়ার স্ক্রিন করুন স্যার।
The interesting thing that I want to tell people is that
স্লাইড শো করুন স্যার।
this actually does not fall.
পিছনে কারটা শোনা যাচ্ছে বলো তো?
না, আমার আরেকটা চলছে, সেই জন্য আমারটাই চলছে। আমার এখানে যে দুটো হচ্ছে, আপনার আমাদের আইসি যেটা হচ্ছে আর একটা হচ্ছে। আমি অফ করলেই অফ হয়ে যাবে। ঠিক আছে, শুরু করুন স্যার।
অফ করো তুমি। Good evening, everybody. My topic today is dysmorphic short stature. Now, I'm a self-style syndromologist, but whatever I have learned about the syndromes is because of these two legends, Professor Dr. Shishir Bose, whose birth centenary is going on, and my guide, Dr. S.P. Ghoshal, who was again born in 1920 and birth centenary is going on. I learned a little bit of radiology from Dr. Shishir Bose, who is one of the pioneer in pediatric radiology, and Dr. Ghoshal, who had a knack towards the syndromes and uncommon diseases. Why should an endocrinologist learn dysmorphology? I will show you in some cases where there is an overlapping between a endocrine disorder and a syndromic disorder. Now, the syndromes may be tall or short. I will talk on short statures, but just few lines that the syndromes with tall stature may be proportionate. They may be dysmorphic like Fragile X, Sotos, and Weaver, or maybe Beckwith-Wedman, Klinefelter, Marfan, and homocystinuria. But I'll talk on short and syndromic, and of these, short stature with dysmorphic features, mild or no mental retardation, or short stature with moderate mental retardation. We can divide the short stature into disproportionate, which will be skeletal dysplasia. I will show you some cases, and proportionate, which may again be syndromic and non-syndromic. Now, amongst the non-syndromic short stature, what we need to look for, whether they are associated with congenital heart disease, like Noonan, Turner, all of you know, velocardiofacial, Williams, or skin abnormalities like Coca and Bloom, and limb defect like Ashcock, Cornelia, and some Rubinstein-Tabes, Russell Silver, Sickle. So there are plenty of syndromes. I'm not going into the details. I will show you some cases amongst this list. But before that, I want to tell you that being short is not always a curse. And you know, the Maradona had a very lower center of gravity, and that's the reason he could play better. Sachin could play better than Tony Greig because again of his center of gravity, and similarly is the Messi. Now this man who was short, and this is called Tolesi-Lortek syndrome. Don't get upset by this name and the rare disease. But once I come to the disease, you'll be able to know. This man survived only for 36 years. And this picture, she was a very good artist. And this picture was sold after 100 years of his death at a price of 164 crores. 164 crores, that's the record. Now, one of the main problems that we find in our country's teaching, that we learn a lot about pathophysiology of a disease. We learn a lot of junks, which is not necessary. First of all, you need to diagnose the patient, and then you can think of, but if you do not diagnose the patient, what's the point in learning a lot of pathophysiology? The reason I'm showing you this 100 pediatric picture test is that, see, this book, the cover page contains this disease. And the question in this Asian boy presented with a short stature, what is the most likely diagnosis? To you, it might appear, oh, this is so rare. But no, that's how it is being taught in the Western countries, that even if it is a rare, you need to diagnose. The first day when I went to my clinical class, my teacher told me, never diagnose a rare disease and you'll be rarely correct. I fully agree with her. She was a lady. I fully agree with her. But never ever think that rare diseases collectively are not that uncommon. They are quite common. And to the family, it's very common. It's almost 100% in those families. So this child came to me with the problem of short stature. And what I find is the receding chin, the blue sclera, and the short stature. And the tooth is very crowded, as I have shown you in the picture, that the tooths are very crowded and overlapping. The fingers, as you see, is slightly small here. And when you do the X-ray, you see this is the hypoplastic. There were Wormian bones. Now the clavicle development, if you know, the medial part develops from cartilaginous and lateral part develops from the membranous. And the clavicle, the osteolysis of the lateral part of the clavicle is in this disease, and the same in the other side. And when you do the X-ray, it looks almost like a marble bone disease or osteopetrosis, and the vertebrae are spool-shaped. Can you see this? It's like spool-shaped vertebrae. And this spool-shaped vertebrae and all the other features, what I have told you, gives you the diagnosis of pycnodysostoses, which was very nicely described by my colleague, Dr. Sukanto Bhattacharya, as the pycnodysostosis. And the pycnodysostosis and osteopetrosis are very close. But in case of pycnodysostosis, there is short stature and it is autosomal recessive in disease, commonly missed as this osteopetrosis. In fact, the Tourette syndrome, the artist that I was mentioning, he had the pycnodysostosis, and because of that, he had recurrent fractures, and then he died at a very early age. And one of the differential diagnoses may be Ghoshal hematodiaphyseal syndrome. And Dr. Ghoshal, as I said, is very few Indians who has the disease in their own name. And Dr. Ghoshal is one of those who had the disease in his name. And this is Ghoshal hematodiaphyseal syndrome, which he described in 1988 as in Indian Journal of Pediatrics from USA. And Oxford database contains Ghoshal hematodiaphyseal dysplasia. Now, this is a disease came to us with a very short stature, without a diagnosis from Bihar, without a diagnosis. And then subsequently, we diagnosed the disease. We found out the gene, and this is a laminaceae gene, which is progeria. And this is the largest progeria family. This is the largest progeria family in the world. And what you see in this progeria family also, the clavicles are not there. So we have diagnosed the disease. And the importance of the diagnosis of these syndromes, the importance of the diagnosis of this disease is that syndromes is that This child came to me with a short stature and failure to thrive, was seen in the cardiology and was found to have a coarctation of the aorta. But look at these eyes of this child. These eyes are very characteristic of Kabuki syndrome. And in Kabuki syndrome, 30% of the cases will have the coarctation of the aorta. So if you don't think of the syndromes, you will be missing, you will be treating only the coarctation, but not the Kabuki syndrome part. And similarly, this is another Kabuki syndrome, which is rare conditions, but I have seen at least 3 to 4 cases of Kabuki syndrome in my life. And there are 2 genes, one described from Washington and one from Belgium. These are the genes. Now you can have the genetic diagnosis. Now this is a child where you can see there is polydactyly, but their main concern was failure to thrive and the short stature. This child also had microphallus and hypospadias. Now microphallus, hypospadias, postaxial polydactyly. So we went for an MRI brain, and the MRI brain showed that there is a hypothalamic hematoma. And with this, all the pictures, it becomes a Hall-Pallister syndrome. And about 5% of the hypothalamic hematomas are Hall-Pallister syndrome, which is in chromosome 7. Chromosome 7, as you know, is notorious for many, many diseases. This child came to my clinic in hospital, and looking at the child, it took only a few seconds to diagnose, but till the 13 years, they didn't have a diagnosis. You look at the hair, you look at the short stature, so it becomes a cartilage hair hypoplasia. It's uncommon, rare, but it's there. And the parents wanted a diagnosis. This is what happens. The parents first wants a diagnosis and also the cure. You may not cure, but you can give them the diagnosis. The importance of the diagnosis in this case, that they have a T cell deficiency. And if they have chicken pox, it's really dangerous for them. So they should be vaccinated for at least chicken pox vaccine. And what you see that the hands and the feet, most of the joints are hyperextensible, excepting the elbow, which is decreased extension. And you do the radiological changes of cartilage disease. Chromosome number 9. Now this child was brought to my room thinking that it might be a syndrome. But looking at the child, it's not a syndrome, it's an endocrine disorder, and it's a Cocker-Debris-Semmelweis syndrome. So there is some overlapping, sometimes syndromes and sometimes endocrine disorders. So severe hypothyroidism presenting as Cocker-Debris-Semmelweis syndrome. And as you can see here, the epiphyseal dysgenesis, which we don't see nowadays because of the early diagnosis by the endocrinologist and also by the pediatrician. So after treatment, this child will be all right. So there are common skeletal dysplasias, and there are some uncommon. I will go few skeletal dysplasias which I have seen. This is achondroplasia. Very characteristic square-shaped iliac bones, and then ice cream scoop-shaped femur. I'm not going into the details of that. And what you see is the bullet-shaped vertebra and the posterior scalloping of the vertebra. And this is a bullet-shaped and posterior scalloping, very classic. Now, one of the questions that you might face, see, both the parents are achondroplastic. There is a chance that one achondroplastia patient will get married to another achondroplasia. The question is that they have a chance of having an achondroplasia child, number 1. And number 2, they can have a severe homozygous achondroplasia, which can be lethal in womb also. One question you might face, suppose someone has one normal girl and one achondroplastic child. Now, during a marriage, the boy's family might ask, if my son gets married to this daughter who is normal, from a normal parents, but have an achondroplasia son or daughter, what is the chance that my son, after getting married to this family, will have an achondroplasia? It's not a zero, it is 0.02%. That means 1 in 443 because of the germline mosaicism. And that is the reason in case of achondroplasia, the parents are normal, but they have a chance of achondroplastic children because of the gonadal mosaicism. Now, achondroplasia is easy to diagnose, but this child, if you don't undress this child, you will not be able to miss this. They went to the a doctor, and the doctor thought that it might be a constitutional delay in growth and puberty, did a bone age, and that was the end of the story. But once you undress the child, you can see the lordosis. But he doesn't have the features of achondroplasia, classic achondroplasia. He doesn't have the features. This is actually hypochondroplasia. The same FGFR3 gene in chromosome 4, but much milder variety of hypochondroplasia. And see this, he has got some bony changes of achondroplasia, and the interpeduncle distance are also decreasing. I'm not going to the detail. So that's what I said, that hypochondroplasia may be confused with idiopathic or familial variant, but the macrocephaly appears to be discriminating factor. Now, one important factor, I don't have the picture, is the pseudoachondroplasia. Now, how do you differentiate between this pseudoachondroplasia? Pseudoachondroplasia will have all the features of achondroplasia excepting their head and face are normal. And that's pseudoachondroplasia, as you can see in these children. They have the genetic, now we can diagnose them by doing a cartilage oligomeric matrix protein, the COMP gene. Now, the same COMP gene can be seen in multiple epiphyseal dysgenesis. Now, you can see these epiphyses are dysgenetic, which looks like hypothyroidism. Sometimes they are even confused with Perthes disease, but multiple epiphyseal dysgenesis is one. But they have the same COMP gene. Metaphyseal dysplasia is another short stature, and this is one of the cases of camptomelic. You see the bones which are bent. This is camptomelic dysplasia, and this is one of the presentations papers that we have on camptomelic dysplasia. This is interesting. It's called metatropic. The reason it is called metatropic is because initially their spine is normal and limbs are shorter. But what happens over the time, their spine gets bent and bent and bent. That means kyphoscoliosis. The height becomes less, and they have a tail-like appendage. Tail-like appendage, and this is metatropic dystrophy. And initially, they are normal body length. As I said, that's the reason it's called metatropic. This metamorphosis takes place. This is metatropic, and then later on it becomes shorter. And this is the tail-like in metatropic dystrophy. This is a family with both the children suffering from metatropic dystrophy. We have published two cases, metatropic dysplasia. Now, this child again is short. Very nice looking, pretty looking child with short. But what you see here is the narrow sacrocytic notch and spinous projection and a very narrow, short chest. And this is called thoracic dystrophy. What you find in the thoracic dystrophy is that this handlebar type of clavicle. Can you see this? Clavicles are very high up and handlebar type of clavicle. Now, in this aspaciated thoracic dystrophy or thoracic dystrophy, the follow-up is necessary because they can have a renal cyst, pancreatic cyst, and liver cirrhosis. So the follow-up is necessary. Now, this is a baby. They came to us with multiple fingers, polydactyly. But if you look at the nails, they are very small. The chest also are very small. So this is a chondroectodermal dysplasia because there is ectodermal, the nails are very hypoplastic, and the chondro means their chest is very short. So this is chondroectodermal dysplasia or Ellis-Van Creveld syndrome. Now, this is the same disease, the girl with polydactyly, and what you see here is a very conical teeth, chondroectodermal dysplasia. They have a high chance of cardiovascular abnormalities, and one needs to look for these. And there are two genes, EVC and EVC2. Nowadays, we can diagnose by doing a genetic study. And then chondrodysplasia punctata, look at the calcifications that you see with the short thorax and short limbs, and with the calcifications, you see that the chondrodysplasia punctata, and look for the cataracts in these cases because they may be associated with this. This child came to us with a respiratory tract infection. But what we found in the chest X-ray, which was not read properly, that there is no clavicle. And there are plenty of Warmian bones in this. And then this is the same child at the age of 14 years, few months back, there is still no clavicle, and this is a pedocranial dysostosis. What you see in this child is ptosis, antimongoloid slant, and a cardiac operation. Now, Noonan syndrome can present like this. They can have pulmonary stenosis, and this stenosis in these cases is because of the dysplastic valve, and you may not be able to treat this with a balloon valvotomy. You might need a surgical operation. This is another Noonan syndrome, and this is another Noonan syndrome. Now, this child came with the failure to thrive, severe failure to thrive, and we did the genetic study, and then it was shown that its PTPN11 gene is abnormal. Now, Noonan is actually a RAS-MAMK pathway defect, and a lot of diseases are similar diseases like Legius, cardiofasciocutaneous, neurofibromatosis, Costello syndrome are of the similar pathway disease. I'm not going into the details, too much genetic in there. This is a female Noonan, it's a male Noonan. This term should not be used. That's the reason I'm showing you. This Noonan is Noonan. It can be in male or it can be in female. One should not use the male Noonan or female Noonan. And as I said, 50% of the cases are in Noonan PTPN gene on chromosome 12. And remember that the chromosome 12 genes is also for the von Willebrand abnormalities, and they can have bleeding disorders and also clotting factor deficiencies like 8, 9, and 12. If you look at this child's smile is slightly different. He's trying, but he's not. It's not proper. I cannot describe this, but it's not proper. Actually, this child has a velocardiofacial facial deficiency. Means it's a Noonan syndrome, but his soft palate is defective. That's what happens in cardiofasciocutaneous syndrome or Diagnostic syndrome. Sorry, this is a Diagnostic syndrome or catch-22 syndrome, which you, whatever you call it, 22q11 defect. And this is a proved case. This is another case of Diagnostic syndrome where the nose is tubular. Now, what you have in Diagnostic syndrome is high chance of heart disease. And I have seen many cases of fellows being operated without checking for the 22q11 deletion syndrome. Now, in 15% of fellows, you will have 22q11 defect, And in 50% of fellows with pulmonary atresia, because you know that the Diagnostic syndrome is a third and fourth arch defect, there will be a 22q11 defect. This child is deaf, short, and multiple lentigens, was not having a diagnosis, was going from one place to other. He had a pulmonary stenosis, and this is actually a leopard syndrome. Though I personally don't like the use of this leopard syndrome or giving any disease a name to an animal or something like that, Wolf syndrome or happy puppet syndrome, these terms should not be used because this is quite traumatic to the parents. The Costello syndrome is again of the same RAS pathway group disease, and this is another Costello syndrome where they're initially large at birth, but they become short gradually. They become short with postnatal growth deficiency, and the hands, they have the wrinkling of these hands and feet, and that's very characteristic of Costello. Coming to this disease girl, you have seen already, you have heard already that this pectus carinatum and excavatum combination, or this short fourth and fifth metacarpals, is very characteristic of Turner or Noonan or pseudo hypoparathyroidism. But this child is a Turner. You have discussed, but this is a twin with Turner. Now the question about this is that if they ask you that what is the chance that my next child will be Turner syndrome, difficult to answer. But remember, Turner syndrome is during the defect in the meiotic division, not in the mitotic division. The chance of recurrence is much less. Chance of recurrence is actually 1.2%, and but a lot of Turner being aborted. So that's a question that you might face. Now, this is very classic Turner, but what I want to stress that more the webbing, more the coarctation. The coarctation is 11 times more common if you have got a Turner with severe webbing. So you need to look for coarctation seriously in these cases. Same thing with Noonan with webbing, you will have more chance because this is jugular lymphatic defect, also cause cardiac defect. Very interesting is that the Turner syndrome that you inherit from the father at the Turner's X chromosome or the mother carries different meaning. And it has been seen in patients of 80 Turner syndrome that members of 45XP group, means paternal group, were significantly better adjusted with superior verbal and higher order executive function skill, which mediates social interaction. So if you can identify that this X chromosome, which the girl is having, is from the father or from the mother, you can give some guidance about their future careers. The Turners are, you know, very poor in visuospatial orientations. Even if a Turner can be doctor, but they should never be an echocardiologist or because they are visuospatial or ultrasonologist, they cannot be very good. Williams is very commonly missed. The reason they are missed is because they go on talking, they are nice and talking, but you know, they are highly loquacious girl, because again, a defect in the 7 chromosome. This is a Williams syndrome, which was missed because the boy looks normal. And this is again a Williams syndrome, which is diagnosed at the age of 4 years when they came to me. This is an Arscock syndrome. Their presentation is short stature, but what is interesting in these cases, they have a shawl scrotum. The scrotum skin goes above this. I will show you this picture. Again, this is another scrotum child with shawl scrotum. Arscock syndrome is that this shawl scrotum. Very classic diagnosis. If you see eyebrows heavy in a baby, and if the parents are not having heavy eyebrows, this is a very soft sign of dysmorphism, and one needs to be very cautious about the diagnosis. Look at the eyebrows of this child and look at the hair of this child. But if you have this type of features, then you know this is a Cornelia de Lange syndrome, which is quite uncommon. And this is again, look at the eyebrows, and this is a Cornelia de Lange syndrome. If you see a finger like this, which is like a hitchhiker's thumb, and the nose is very characteristic, is Rubinstein-Taibi syndrome. And their presentation is the short stature, developmental delay, and 1 in 125,000 patients have Rubinstein-Taibi syndrome. This is a disease. I don't know whether it's in one end of IUGR or severe IUGR, the clinodactyly, short stature, large head. But remember, clinodactyly is present in 18% of the normal population. And as you can see, the incidence of the disease may be 1 in 3,000 or 1 in 100,000. The Russell-Silver syndrome, again, a disomy of chromosome 7. As I said, the chromosome 7 is notorious. So Russell-Silver syndrome, they are short and they have clinodactyly, but they may be otherwise normal. But the same clinodactyly in a child who is otherwise very dysmorphic, and this is called Seckel's bird-headed dwarfism. Seckel syndrome or Seckel's bird-headed dwarfism, they usually have a very low birth weight of 1.5 kg and developmental delay. Now, this child has no fat. He looks like very muscular. He looks like very muscular because there is no fat. And there is a severe degree of acanthosis nigricans. And the incidence of this disease is 1 in 10 million people worldwide because of the two genes, AGPAT2 and BACL2 genes. And this is called lipodystrophy or Berardinelli-Sip syndrome. This is one patient, but they may not have the short stature. Just because it's an endocrinology forum, I'm showing you these cases that they can have severe diabetes, hepatosplenomegaly, hypertriglyceridemia, and others. This is another lipodystrophy that you can see, Berardinelli-Sip syndrome or Lawrence-Sip syndrome. This you know very well that mucopolysaccharidosis may present as short stature, and Fanconi's anemia can present. The thumb abnormalities is very characteristic of Fanconi's anemia. As you can see, Fanconi's anemia and scoliosis, and they present with short stature. So if you have a short stature with thumb abnormalities, think of Fanconi's anemia. If you do not think of syndromes or rare diseases, this child went to South because of the failure to thrive from Tripura, went straight to the South. There they did a CT scan, but the CT scan was very characteristic. They didn't give the diagnosis, but kept the CT scan with them because it was very classic, teaching basal ganglia calcification. When this child came to us, what I found that there was some thin rashes on the nose. Initially, I thought, is it a xeroderma pigmentosa because of the DNA repair defect? Because the parents said that the facial rash on sun exposure, which is characteristic of xeroderma pigmentosa, his weight and height were much below the centile. He had intention tremor and ataxic gait, and skin, as I said, erythematous and scaly. We did a fundoscopy, and it showed salt and pepper retinopathy. This is salt and pepper retinopathy. This is not the patient's CT scan because they have kept the CT scan with them, but this is what type of calcifications you see in basal ganglia. We did an MRI because we wanted to avoid another radiation, and there were bilateral calcifications of the basal ganglia and cerebellum. This is Cockayne syndrome, presented with short stature, failure to thrive, and skin rash. Didn't have the diagnosis till someone started thinking of this rare case and got the diagnosis. The growth chart, the importance of growth chart, Dr. Shubhankar Chaudhary has said that the growth may be defective, but look at this growth chart. If you find a child growing from a low birth weight to such a severe high birth weight, always be suspicious. Always be suspicious. This is the point when the intervention started. And this is a similar growth chart in another female. And you see very low birth weight and then started growing very well. Don't be very happy. The parents will be happy, but you should not be happy. You should start thinking of one diagnosis, that is Prader-Willi syndrome. And we did a fish study in this case, and there was a defect in SNRPN gene in this case. So Prader-Willi, the definitive diagnosis is DNA methylation, but the fish will be positive in 70% of the cases. Similar syndrome to Prader-Willi, hyperphagic psychosocial short stature, a clinical review. This is a new entity where they will eat. There is a criteria, I'm not going into the details, but there will be Prader-Willi negative. There will be Prader-Willi negative. If you think of Prader-Willi, you also think of Angelman syndrome. This is a child totally unlike his parents. Look at the eyes, look at the hairs. He had a seizure. He was very happy, like a happy puppet syndrome. And this is Angelman syndrome. Again, not a very common condition, but we do miss Angelman syndrome because we don't think of it. Then is the Bardet-Biedl syndrome. Both the brothers is the Bardet-Biedl syndrome, polydactyly, but the name has been changed from Lawrence-Moon-Biedl syndrome to only Bardet-Biedl syndrome because Lawrence-Moon has the paraplegia and they are not obese. So investigations, I don't need to think that I will discuss on this investigations, but genetic studies are ones we think of. Syndromology, Oxford Medical Database, there are a lot of software, so I can put the information and they will suggest you that this might be the possibility, and the new software that compares with an individual's face with a bank of 3D images of people with known condition is aiding the diagnosis. So this is another which is coming up, and we should think of that. And again, at the end, I say that never think of rare disease, you'll be rarely correct, is not always right. You need to think of sometimes rare diseases when your common diseases fail. Thank you.
Thank you, sir. Thank you. Ma'am?
Yes. I'll try once more. And I'm very sorry for the interruption, but it was totally out of my control. Am I audible now?
Yeah.
Okay.
Yes.
Yes. So I think there was a lot of interruption. So I'll just hurry through my slides. The first part where there was that interruption. These are the topics, headings we will look into today: indications, targets, initiation, titration, defining poor response, monitoring, growth hormone therapy during puberty, role of adjunctive therapy, therapy during transition phase, adverse effects, and safety issues. This is the timeline, and as you can see that with the availability of unlimited supply of recombinant growth hormone from the 1980s, the indications have gone beyond severe growth hormone deficiency disorders to non-growth hormone deficiency disorders, and includes syndromes and systemic illness. This is the list as it stands right now, the list of approved indications. I will be restricting my talk to the growth hormone deficiency disorders in children. And the targets, I think, are very important. We initially have to provide the catch-up growth and enable the child to reach his genetic height potential. We need to synchronize growth and puberty. And of course, we want to achieve a final height which is consistent with the mid-parental height or is acceptable for the relevant population. Metabolic benefits are of relevance only in severe GHD in children. And psychosocial benefits, again, remain a very dicey area. We don't have enough data to show that a specific height gain does sort of confer a lot of psychosocial benefits. So when do we start? Needless to say, as soon as the diagnosis is established, we start treatment, and the earlier we start, longer is the prepubertal window for catch-up growth, and better is the adult height outcome. And if we are starting growth hormone late in the course, near about puberty, then it is important that we ensure that episodes are open. Baseline parameters, of course, have to be documented, and we need to sort out financial issues with the parents. That is very important. And also the parental expectations, they should be grounded, because we don't want any unpleasantness at the end of therapy. The injection is given subcut. It's given in the evening hours. Daily therapy is more effective than thrice weekly or 6 times weekly. 1 milligram equals 3 units. Pens are definitely preferred because of the ease of administration and the accuracy of the dose. And sustained release preparations are in different stages of development, and they are even available in some countries, but we have to await long-term data on safety and efficacy before they can be used on a widespread basis. The starting dose would be based on the weight. The recommendations are to start with a dose of 25 micrograms per kg per day. If the child is having severe short stature, severe growth hormone deficiency, we can start with a lower dose. And if we are looking at the dose requirement in infants and obese children, it's better to go by body surface area adjusted dose. Now, this is the expected height response. In the first year, it's around 10 to 12 centimeter. In the second to third years, it's around 7 to 9 years. But having said that, we must remember that there are large variations in growth response even at the same dose. Now, to the left, you have a chart which shows you what a good response looks like. To the right, you have a chart which shows you what a poor growth hormone response looks like, and that too at double the growth hormone dose. So the moment we get a poor response, and it is actually defined according to the latest article published in 2019, it is defined as a height velocity less than 2 centimeter per year, height velocity SDS less than 0, and a height SDS less than 0.3 per year during the first 12 months of therapy. And what do we do if we find that the child is not responding well, is not growing well? We sit back and think that what could be the causes of this poor response? And heading the list, of course, is the subtherapeutic course of growth hormone. We are giving the child insufficient dose. I'll come to that in the next slide. Apart from that, there are compliance issues, technical issues. Hypothyroidism may have been unmasked during the course of growth hormone therapy. There may be coexistent malnutrition or diseases like celiac disease. Those with prior spinal irradiation, the growth hormone response may not be as expected, or there could be concurrent mild growth hormone insensitivity. So that brings us to the very important issue of titration of the growth hormone dose. Now, most of the guidelines recommend that it's actually the height response which is the best parameter for assessing the adequacy of the growth hormone treatment. So we look at the height velocity, we look at the height SDS changes, and that would give us an indication as to whether we are giving the correct dose. But apart from that, there is another parameter, that is the IGF-based titration of dose, which, however, has a lot of pros and cons. Actually, it's been seen that when we use IGF in dose adjustment, we land up using higher dosage of growth hormone. And not only that, the other disadvantage is that there is no clear cut, cutoff that, okay, this is where I should keep my IGF level to get the best outcome as far as the adult height is concerned. So most of the guidelines do not endorse IGF for dose adjustment. However, they suggest that IGF should be done, and it should be done for monitoring compliance and also for safety issues, because we don't want supraphysiologic doses of IGF. So we measure IGF, say about 3 months after starting therapy or after changing the dose, and then annually. And we try to keep the IGF in the upper half of the normal range, that is between 0 and +2 SD. Now, we need to look at the thyroid axis very carefully before and during the growth hormone treatment in the child. And I'll tell you why. This is because before we start growth hormone therapy, it is important to ensure that the child is euthyroid, because abnormally low T4 levels actually impair response to growth hormone. So we ensure that the child is euthyroid. Then again, once we've started growth hormone, we need to monitor thyroid function tests from time to time for 2 reasons. First is that growth hormone actually enhances the conversion of T4 to T3, so we may get a transient decline in T4, but that occurs in only about 1/4 of patients, and it does not have much clinical significance. The second reason is more important, why we should do a TFT regularly. That is that because the central hypothyroidism may be unmasked in patients with multiple pituitary hormone deficits while they are on growth hormone therapy. And it's for the same reason that we should monitor cortisol as well as ACTH levels when we are monitoring the child on growth hormone therapy. Okay, so that brings us to the issue of monitoring. What should we look at? We should assess the height, weight, and pubertal status every 3 to 6 months. We must do the bone age annually. We should check glycemic status, because though very rare, but growth hormone therapy may precipitate IGT or even type 2 diabetes. I've already talked about the importance of doing the TFT. First at 6 months, then annually. I've discussed the importance of doing IGF-1 annually. We must exclude other pituitary hormone deficiencies, exclude adverse effects of growth hormone therapy, and of course, we need to check the technique, dose, and compliance at each visit. Now, next we come to an interesting area, that is the growth hormone therapy in the pubertal phase. Now, we all know that the pubertal height gain actually contributes significantly to the adult height, and growth hormone levels actually increase 2 to 4-fold during puberty. So, in sync with this physiology and based on several RCTs, the FDA actually suggested that we go for higher growth hormone dosing to the tune of 0.7 milligram per kg per week in children during puberty, in all children during puberty, because this has been shown to give an additional roughly 4 centimeter extra height benefit. But then again, there were the guidelines who were contradicting this recommendation, and they said that it cannot be a blanket statement. It has to be individualized. Like, for instance, the child who's started on growth hormone late, close to puberty, or whose height is extremely short at the start of puberty, these would be the ideal candidates where we would think of increasing the growth hormone dose. Now, what about adjunctive therapy? That is the addition of a second agent to growth hormone, which would maximize the height benefits. And the first, the option that comes to our mind is the GnRH analog. And there has been convincing evidence that when we are starting growth hormone treatment late, in the growth of the child, maybe during the early or mid-puberty, there if we add GnRH analog, then that results in a taller adult height. But there is a flip side to this treatment also, because at least 3 years of treatment is needed to get this height benefit. And that would mean stalling puberty with its psychological consequences. It would mean a detrimental effect on the BMD. And of course, it would incur additional costs. So again, this addition of GnRH analog is not recommended routinely. It is recommended again in those who are diagnosed late, close to puberty, or the puberty is early and rapidly progressive. The other adjunctive therapy that was considered were the aromatase inhibitors. We do not have data in girls, but in boys, they again did show some short-term growth outcomes in male children, but there was no convincing benefit on the final adult height. And moreover, some vertebral deformities have also been reported. So then again, it is not very much recommended mode of therapy right now. Okay, so after all this, we come to the when to stop the growth hormone therapy. The recommendations are that if the height velocity is below 2 to 2.5 centimeter per year, or the child has reached a height which is acceptable to the community or is consistent with the mid-parental height, then also we stop, or if the epiphysis has fused. Now the question is, does the story end here with the attainment of adult height? Perhaps no, because we have this transitional care. We have to keep this in mind. Transition period actually refers to the years from the late teens to the early 20s, when the adult height has been reached, but the individual is acquiring the adult body composition regarding the muscle mass, the body composition, the body fat, and also the bone mineral density. And actually, it was seen that when we re-evaluated children during this transition phase, about 2/3 of those with idiopathic isolated growth hormone deficiency had normal results, and so there was no need to continue. However, patients who have got more than 3 pituitary hormone deficiencies or a defined genetic mutation or have major structural defects in the pituitary hypothalamic zone, they are the ones who are having persistent GHD, and we should continue therapy. Here, there is no question of retesting. But if it is a case of isolated growth hormone deficiency, or there is deficiency of only one additional pituitary hormone, or we have minimal structural changes in the form of just an isolated small pituitary or an ectopic posterior pituitary, then these candidates definitely need re-evaluation. And IGF-1 should be the initial test of re-evaluation. Only if that is low, we go for growth hormone provocative testing. And it is seen that if growth hormone is offered to individuals with persistent GHD in the transition period, there is definite evidence of benefit. Okay, so after all this hype, after all this effort, after all this amount of expenditure, what is the outcome? So let us look at the adult height outcomes. Now, we have data from both the KIGS database and the NCGS database, and the KIGS data, I think, is more encouraging. And if you look at the change in height SDS, it is very impressive. And if you look at the difference between the height and the mid-parental height, then that too, the results are very encouraging. But as I said, there is a variability of response. So what would be the predictors of good height gain? The younger the child is started on therapy, the longer is the duration of therapy, more severe is the growth hormone deficiency, more is the height deficit at initiation, greater is the catch-up growth in the first year of therapy, taller parents, and increased height at onset of puberty are some of the predictors which indicate good adult height. And recently, the research is on, the research going on regarding the GHR gene polymorphism and what role they have to play in the final adult height. Coming to the adverse effects of growth hormone therapy, thankfully, it's fewer than in adults. It's only around 3%. But then again, I think we should all remember that they do occur, and unless we are wary about them, there is a risk of missing them out. For instance, idiopathic intracranial hypertension, if the child is complaining of headache, vomiting, or some visual disturbance, then we definitely need to take action. If the child has a pain in the hip or is limping into your clinic, please consider a slipped capital femoral epiphysis. Pre-existing scoliosis may get worsened. That apart, you have a long list as I've enumerated here. Diabetes, as I said, may occur, but it is rather rare. And of course, we may have to deal with injection site reactions. Now, the last part of my talk would be regarding the safety issue of growth hormone therapy. There have been concerns whether growth hormone therapy increases cancer risk. And in the initial part, in the early years, actually it was seen that there were case reports of leukemia and also publications, as after growth hormone therapy. But subsequently, larger and longer studies have sort of negated this increased risk for leukemia or non-leukemic neoplasms. Now, coming to more recent data, this is data from the SEDGE European cohort study published in 2017. And as you know, this study on the safety and appropriateness of growth hormone therapy in the European cohort is one of the largest and longest study. And they came up with the finding that in childhood cancer survivors, though there was a minimal recurrence of the primary lesion, there was a modest increase in risk for second neoplasms, especially Hodgkin's lymphoma with long and lung cancer. But then this was again criticized because they said that there was no active comparison with children, cancer survivors who did not receive growth hormone therapy, and some other limitations also in the study. And the following year, in 2018, there was this was a meta-analysis which showed that actually in childhood cancer survivors also, there was little or no increased risk for second malignancy except benign meningiomas, and that too after cranial irradiation. And because tumor recurrence is generally not increased, the recommendation is that we wait for 12 months to sort of ensure tumor safety after completion of tumor therapy. And then we can start the child on growth hormone therapy. But it is, of utmost importance to go for long-term post-treatment surveillance. And the recent concept that is forming is that the risk of cancer actually depends on the underlying cause and what treatment modality the child has been subjected to, particularly whether the child has received radiation. And this is my last slide. Again, published in August this year, which shows that, again, the results from the SARG study, which shows that they have sort of classified the patients into low risk, medium risk, and high risk. Those with isolated growth hormone deficiency, idiopathic short stature, SGA, they actually fall in the low risk, while the multiple pituitary hormone deficiency and the different syndromes are in the intermediate risk group, and the highest risk group would be all malignancies, chronic renal failure, and of course, those who have increased risk of cancer with chromosomal breaks, etc. And so they concluded that in patients treated with human growth hormone, all-cause mortality was associated with underlying diagnosis. And in patients with isolated growth hormone deficiency or idiopathic short stature, growth hormone treatment was not associated with increased all-cause mortality. However, mortality from certain causes are increased, emphasizing the need for further long-term surveillance. So take home, therefore, ladies and gentlemen, is that In children who have got profound growth hormone deficiency, growth hormone treatment therefore clinically benefits them, so much so that the benefits clearly outweigh any potential harms. Of course, adjusting dose is challenging due to the variability in response, and we need to individually optimize dose. However, a final word of caution before I sign off. There is actually limited data, as I said right at the beginning, to support that a specific height or height gain has psychosocial and quality of life benefits. Therefore, treatment with growth hormone is not indicated in every child with short stature. The decision to treat will depend on the parent's height, the ethnicity, the family perceptions, and affordability. And at the end of the day, it calls for the rational, pragmatic approach on the clinician's part. Thank you for your patient listening.
Thank you, Motushi, for your excellent presentations. If there is any questions, if anyone wants to ask. Professor Chaudhary is there?
Yes, I'm there.
Yeah.
Yes, I'm there.
Yeah. Any questions? I think there is no question.
So I think we enjoyed. I learned a lot. Of course, couldn't learn, but of course, went through a whole lot of syndromes that you presented. Hopefully, we remember some of it, part of it. And for Hriday, I enjoyed his talk. I just wanted to know from you both, how often do you get a low IgA as along with the anti-TTG when we are evaluating an anti-TTG?
See, 1 in 300 to 1 in 500 population is IgA deficient. So it's
Very
quite
rare.
common.
Very
it's
rare
quite,
occasion that we found.
Sorry? Hriday, ki bolchili?
It's very rare that we found selective IgA deficiency. It's very rare occasion, I think.
মানে কি বললাম না, রেয়ার মানে I couldn't
Rare
follow
means,
your No, it's not that uncommon.
I think
IgA deficiency is the commonest immunodeficiency disorder in the tune of 1 in 300 to 1 in 700 populations. So, and also IgA deficient patients are more likely to have celiac disease. So the dictum is that in all patients of suspected celiac, you should have a total IgA level, as you say. One question from
yeah, I've seen there's a question for me.
Yeah.
For calculating target height range. Yes, I mean, there are different figures that have been used, even sometimes 7.5 centimeters plus minus is used. Just, I mean, essentially one has to demonstrate that this is not a single figure that we can predict with certainty. There is a range we can predict. However, possibly if rather than just the mid-parental height, if you are doing the correction for regression towards mean, maybe after that, the variation or the range is a little bit shorter, maybe plus minus 5 centimeter would suffice, but not everyone will fall even within this. And as we can well realize, plus 5 centimeter, if you add to that minus 5 centimeters, so 10 centimeter is 4 inches. So that is a huge difference. So clearly we still do not know to predict that well. That we have to accept, but we also need to counsel our patients, or more importantly, our patients' parents as to what to expect.
I'd just like to ask, it was not in today's discussion, but something which sort of confuses me a little is about gonadal steroid priming before growth testing. I'd like Shubhankar's opinion on this. mean, whether we should
Yeah.
practice it routinely, if at what age, with what puberty stage, if we could sort of develop some clear on that.
It's I think it's still out there in the open. My personal pragmatic approach is for anyone we are assessing at age, let's say 10 or thereabouts, 10 or above. If you're doing that, then I would rather do a sex steroid priming, simply to avoid the need for a second test. If for the first time the child fails the test, then the question arises, maybe because we did not prime, so we did not get an optimum growth hormone response. So why not get through with it in the first instance itself? That's my view.
Yeah, we
So
want to exclude the false
what we usually
positives.
do
Yeah.
is to
Yes, Rida has a point.
ma'am, what we usually do is that we usually do the sex steroid priming after. You are right that after bone age of 10 and 10 to 11, not the chronological age.
Yeah, maybe that is the time when the gonadal steroids are coming into the main action. And of course, the puberty staging is important. I think it should be less than 10 or 2 at least. I mean,
It's
that
always the it's always the
if it-
practice. Sorry, it's always the practice in UK to do the priming. As Hriday said, when the bone age is more than 10 years, to do the priming with testosterone or estradiol before doing a growth hormone.
Yeah, I mean, so 10, anything more than 10, I mean, you may not require. If there is already significant sex steroid in the system, you do not need. So it's only around that age
Yes.
possibly when you do.
yeah, true.
But do you do the growth hormone provocation test at least 2 types? Because in 30% of the cases, one test might fail.
Yeah. And that's also partly determined by the underlying, and by the time that you do a growth hormone test, usually possibly you've already done an MRI as well. And if you have significant structural changes, maybe even with one test failing and with very strong anthropometric criteria, we may not do a second test. But if the first test shows a satisfactory, reasonable response, but you do not have sufficient growth and there is some structural defect, maybe then we do a second test. So we do not, as a routine, do 2 tests, I must admit. We have been doing in recent times 2 tests essentially to try and get away from insulin hypoglycemia, try to prove that clonidine test is as good as insulin hypoglycemia or glucagon stimulation test. So we've been doing 2 or 3 tests in some patients more as a part of a study to come up with some results. But in general, in most cases, actually, I must say, we land up doing 1 test.
Yeah, I think that is the general scenario. That is what is done. We also end up doing 1 test most of the cases. It's difficult procuring the agents and the side effects, the cost, the availability. There are so many issues that at the end of the day, I think 1 test and relying on other parameters, as Dr. Chaudhary just said. And another
We
thing,
used to do
which,
one stimulation test only
yes,
and do IGF-1 and IGF-BP3.
yes, this is another issue. You know, we just sort of write blanket IGF-1, IGF-BP3, but does it help? I mean, when cost is such a major issue here, is it necessary that we put the 2 together all the time, or can we use them selectively? That is another.
We would usually start with an IGF-1, try and start with an IGF-1 as it's a relatively less invasive, just one-time blood collection, and then go on to a stimulation test. Well, of course, IGF-BP3.
What we used to do is,
in young children, maybe, yes, we would prefer an IGF-BP3.
what we used to do is run the test of IGF-1 initially, and if it is low and it is extremely suggestive of growth hormone deficiency, then you can also run and keep sample for that, and you later on you can run IGF-BP3 because it's costly actually. The cost issue is very important in this.
And I think this is one forum where the message should go out that a random growth hormone test does not have any role in the diagnosis of growth hormone deficiency. I think because this is often advised, except perhaps in neonates only where it has some role. Otherwise, a random, because of its peaks and troughs, it has no role. So that message should actually go out, I think.
I think there is
Okay.
one another question is here. I think Sir will, Dr. Ghosh will maybe interest
Ulta.
for
Is it any other
what next
question?
step of evaluating.
What is that question?
Yes. Sir, from Dr. Parthapratim Chakraborty.
Okay, what is your next step in evaluating a short child with a low weight age, low total IgA and normal IgA and anti-TTG without any obvious history of gluten sensitivity? The question is not really very clear to me. Next step in evaluating a short child with low weightage, low total IgA and normal IgA anti-TTG without any obvious history of gluten sensitivity.
You could do an IgG anti-TTG maybe, because it's not that you are going to
Definitely
get
you
a
should
history in every case.
Yeah.
Yeah.
Yes.
See, if you are
Definitely
IgA deficient, then you need to think of other tests like anti-DGP or anti-gliadin antibodies or anti-reticulin antibodies, but not all the tests are available in our country. But the test that you need to do is the IgG-based test like anti-reticulin test, anti-endomysial antibodies, and anti-DGP.
And again, I think that, short stature may be the only manifestation of celiac disease. It's not that we get the typical history
Yes.
only in a minority of cases, maybe 30 to 40% at the most. So, I mean, looking out for that history may not always be rewarding.
Yes, I mean, I think I am trying to get the DQ2 and DQ8. I'm trying to get that test in our hospital so that if you are DQ2 and DQ8 positive, then you have very high chance, along with other features, that it might be celiac disease. HLA test. So HLA DQ2 and DQ8 is positive in 40% of the population, but if you have got the celiac features and then DQ2, DQ8, then it is highly suggestive of celiac disease. People are now in the world trying to avoid the biopsies also by DQ2, DQ8.
Yes. Yes.
So can you conclude today? Thanks to Mautusi, Dr. Subhankar, Hriday, and my sincere thanks to Sonu for organizing this session. Thank you, Sonu.
Thank you. Thank you very much.
Thank you.
Thank you. Thank you, everybody. Yes.